KarMMa-3 was the first randomized BCMA bispecific CAR T study for multiple myeloma. There was about 386 patients, 2-to-1 randomization that patients got either Ide-cel or a standard of care regimen, such as DPD, DBD, IRD, KD, or EPD. So this was a paper that was published in the New England Journal earlier this year and had a hazard ratio of 0.49 in terms of progression-free survival. So 13.3 versus 4.4 months for CAR T versus standard of care. And what we wanted to look at was how many of the patients that were enrolled actually had high-risk characteristics of their disease. And so really, the treatment of multiple myeloma is evolving over time. And as that happens, we wanted to see, how many patients had been exposed to most of the treatments we've already had, even though this was an earlier line study. So this was for patients who were in third, fourth, and fifth line, compared to those, average was sixth line for the original KarMMa study. And the categories we used for high risk, characteristics were basically high risk cytogenetics, which is a classical reason we call patients high risk. RIS is stage 3 disease, which again, we usually only look at diagnosis, but for these patients that are going on to relapse refractory studies, we might not have that information from diagnosis. So for all the studies, we look at the RIS staging at enrollment, high tumor burden, and we don't have a great scoring system yet, like lymphoma, that we use uniformly for PET positive disease or image positive disease. But here, high tumor burden meant greater than 50% myeloma in the bone marrow. Extramedullary plasmacytomas, which are both paramedullary and completely extramedullary, were included. And then triple class refractory disease, which we're learning more and more that really, even if it's late line versus early line, once patients become refractory to a PI, IMiD, and a CD38, their PFS and overall survival tends to be pretty dismal, and why these new therapies are so important. So in those 5 subgroups or high risk characteristics, we were able to show that patients actually did really well relative to the standard of care. So again, the hazard ratio for all patients was 0.49. And when you look at the, Kaplan-Meier curves for all these high-risk cytogenetics all the way to triple class refractory disease, hazard ratios ranged from 0.4 to 0.86. So those with extramedullary disease, PFS was 7.2 versus 2 months. Versus those with RIS stage 3 disease. We didn't have as many patients. So again, these were, post hoc analyses. So there are some reasons why this is not the best data that we can get, but the first time we're able to do this with this many patients. But in the RIS stage 3 disease, the PFS was 5.2 versus 3.0 months. So again, maybe that could be used as a biomarker to say, maybe we can decrease the tumor burden for these patients before they go to CAR T to actually improve outcomes. And then the safety was very similar. So patients in general did just as well as those patients who didn't have high risk disease. CRS, ICANS, infections, cytopenias were all relatively similar for these patients. In terms of response rates, again, the patients who had the CAR T did better for all of the different 5 subgroups, but some had a little bit lower response rate compared to others. But the CR rates were significantly better for the patients who got the CAR T in the different groups. It's so important that we learn where we need to put all these treatments, right? We have so many myeloma treatments, which is phenomenal that we can get different options for different patients and really, personalize it to what that patient's going to do the best with. But I think CAR T has been one of those things that in the US, it's been approved in 5th line. And there are so many of my patients, I can't get to 5th line to get that CAR T. And so now that hopefully this, as well as some of the other CAR Ts that have been presented, are going to get approved earlier, we'll actually be able to provide access for a vulnerable group, which are our high-risk patients who are not able to get these therapies down the road. I think the other big thing for future is, the study also looked at soluble BCMA levels. And what they were able to see was that at the beginning, at time of screening, patients in both the standard of care versus the CAR T arms all had similar soluble BCMA levels. But when they got treated and at the nadir, we saw much more decrease in clearance of that soluble BCMA level for the patients who got CAR T. And then at progression, the standard of care patients had a much higher level of soluble BCMA. So still more studies to be done, but could this become a biomarker that helps us say, okay, these are the patients who are responding, and when it's coming back, can we use it with MRD to say we need to treat again, especially for our high risk patients? And does this mean that the disease really is different when it comes back from CAR T? Anecdotally, many of us say that myeloma is easier to treat post CAR T than it was going into CAR T. And so, does soluble BCMA have something to be able to monitor that with? And so, again, I think that will hopefully change in the future, where we might finally have a biomarker to help us guide with these therapies.